Hello, we're going to talk about special phlebotomy procedures. This is chapter 13 in your textbook. And we're going to talk about quite a few things in this chapter, which is going to be collecting blood cultures, doing glucose tests, neonatal screening, how to perform blood smears and what they're for. We're also going to talk about blood collection at blood banks for whether you're donating your blood or receiving blood, and a little bit about arterial punctures as well. So let's start with blood cultures, okay? So a blood culture is basically testing for the presence of a pathogen in the blood, because our blood is typically sterile. So when there's a microorganism or a pathogen, a germ in there, it's not a good thing. These patients tend to be critically ill. So accuracy and timing of these tests is critically important for that patient. The venipuncture procedure for this is something you're familiar with now. Of course, we've got to go in the order of draw. And when we're drawing blood cultures, they're always going to go first. The difference is, as we've talked about before, if you're adding blood cultures to your order of draw, you have to cleanse with a sterile technique. Instead of just a regular alcohol wipe, you got to do more of a sterile cleansing technique again. You might be cleaning with chlorhexidine in this case, or the betadine. And the difference with this is you've got to clean with force and friction for a full 60 seconds. Still with the same method, starting at the puncture site, making circular motions going out, but again, force and friction for 60 seconds. If we feel that we need to do a second cleansing again for contamination purposes, we can. What we're doing here, why it needs to be sterile, is because we don't want any normal skin flora to contaminate our blood cultures and give us a false reading. Remember, once you've cleansed that site and you've let it air dry, don't even touch that site with gloves or you are contaminating it and need to clean again. Let's see what's here. Blood cultures can be collected in tubes, and if we use a tube, it's going to be the yellow stopper SPS tube, but more typically, you're going to see the blood culture bottles. Blood culture bottles do come in two different sizes, adult and pediatric, because of the different volumes required for those. The bottles are aerobic and anaerobic. Aerobic meaning oxygen with oxygen or air, and anaerobic meaning without. Let's see. Blood culture specimens do have to be drawn and brought to the lab immediately and placed in a warm incubator to keep them at body temperature. And that's going to allow those microorganisms to grow so that they can be isolated, and the providers or doctors can choose the most appropriate treatment for whatever microorganism is growing. So here's the different volumes. For an adult, we have to have 8 to 10 mils of blood per bottle. With the pediatric, you can see is quite a bit smaller. The amount of blood, if we're not getting enough blood in our blood culture bottles, we're not going to have enough for those microorganisms to grow appropriately. And that's going to cause possibility that we have to rerun our test. And so again, these patients are critically ill. We've got to get this right the first time. You may see a couple different ways that these blood cultures are ordered. You can see them ordered with, for example, it might say blood cultures ×2. When you see that, you've got to get 2 sets of blood cultures, and you've got to draw them from 2 different locations on the body. And when you do that, something that's going to be critically important is that you label those blood culture specimens with all the regular stuff, name, date, time, your initials, but also label them with the area of the body from which they were drawn. You may also see an order that says blood cultures ×2, 30 minutes apart. So you are going to go into your patient, draw a blood culture from one site. You're going to come back 30 minutes and draw from another site. Again, labeling and appropriately is super important here. So the reason that you might get 2 blood cultures or blood cultures done 30 minutes apart is to decrease the risk of getting a false negative result with our blood cultures. So you can collect blood cultures with the ETS system, the evacuated tube system, with the butterfly set, or with the syringe method. Either one is fine. Just keep in mind you're following your regular steps. You're doing the sterile cleaning though, and then you do have to be aware of the anaerobic versus aerobic. And that's going to depend, the order in which you draw those bottles is going to depend on which collection system you're using. So make sure you have an understanding of that. If you look at page 346 in your textbook, you're going to review competency 13.2, and it's going to go through the steps of the venipuncture, steps of the blood culture draw. And then again, also make sure you understand the different order when you're doing a ETS system versus a butterfly system versus the syringe system. Okay. Let's talk a little bit about glucose testing. This is, if not the most frequently ordered laboratory test, it's one of the most frequently ordered. Glucose testing is performed to diagnose, monitor a wide variety of things. And we're going to highlight a few of these right now. Okay. So diabetes. This is when the either insulin isn't being produced. Well, we're talking about diabetes type 2. This is when insulin is not being used properly in the body. If diabetes goes left untreated or it's out of control, it can lead to a lot of different problems like blindness, kidney failure, amputation, and a lot more. Gestational diabetes, on the other hand, is diabetes that occurs during pregnancy and typically goes away after that. There's also hypoglycemia, which is low blood sugar. So we can actually test and look at the levels for hypoglycemia as well. Often when someone is testing somebody's glucose, it's often done at different times and in a series of tests to get a more accurate diagnosis of what's truly going on with the patient. One common test that you're going to probably see and draw is the hemoglobin A1C. This is commonly used to help diagnose diabetes mellitus. Basically, a hemoglobin A1C of 6.5 or higher is considered certain criteria for diagnosing the diabetes. We've talked about postprandial testing. That just means after eating. And a lot of times with glucose monitoring, glucose testing, we might be asked to do a 2-hour postprandial glucose test. If our levels are elevated after this 2-hour postprandial, that's another criteria that can be used to help diagnose diabetes. So you can imagine why it's so important that the timing of this test is done appropriately. If we draw this too early and it's not been 2 hours, we might give false numbers to our provider or our doctor that are saying our sugar levels are really higher than they would have been at the 2-hour mark. And this can affect diagnosis and treatment. We have the glucose challenge test. What this done, and this is frequently done to rule out or check for gestational diabetes. So what happens is the patient is given a dose of an oral glucose solution, usually 50 to 75 grams that they have to drink within 5 minutes. And then 1 hour later, their blood sugar is drawn. If it's within range, we're all good. If it's 200 or higher, it prompts an oral glucose tolerance test. Okay, very similar, just a little more detailed and involved. The oral glucose tolerance test is also, of course, seeing how is our body metabolizing that insulin, or that glucose, right? So for the oral glucose tolerance test here, the difference is we're going to have the patient fast for 8 to 12 hours. We're going to take a baseline fasting blood glucose, and then we're going to give them that oral glucose solution, usually a 75-gram oral solution. As the phlebotomist, if you're administering this test and getting the specimen, you have to ensure that those instructions are followed. So you're going to note the time that this test is started, which is when that glucose solution is drank. And again, it has to be within 5 minutes. You have to finish the whole thing, and they can't throw up. If the patient throws up, we can't do the test at that point. 30 minutes after they have finished that oral solution, you're going to draw blood. Then you're going to do it at an hour, 2 hours, and 3 hours. The important thing to remember when labeling for this particular test is you're going to note the interval and the actual time. So if I draw the 30-minute interval test, I'm going to put 30-minute on the label, 30-minute interval on the label, and the actual time I took it, so 10 a.m. So my next label is going to be 1 hour interval, 11 a.m., and on and on. And recall, just for a refresher, when we're doing anything related to glucose testing, typically we're going to be using the gray top stopper because that has the sodium fluoride in it, which prevents or slows down that breakdown of glucose or glycolysis into acid. So we get a more accurate representation because that glucose, it slows that process down. All right, let's talk a little bit about neonatal screening. So in the US, there are certain tests for metabolic or genetic disorders that are required on newborns. These specimens have to be collected when the newborn is at least 24 hours old. So if they have not been born, if they're not at least 24 hours old and we do that test, it's going to have to be repeated later. Common tests that are done, and I'm going to just talk about these briefly because they're in your book in a little bit more detail. The biotin deficiency, that's when our body doesn't have the enzyme that breaks down biotin, which is used for a variety. We need that biotin to be broken down to aid in other functions in our body, like like the synthesis of fatty acids or the breakdown of amino acids. So if we don't have biotin, we can have problems like vision and hearing loss, movement imbalance disturbances. We can treat this with biotin supplements. Cystic fibrosis. Most of you have probably heard of cystic fibrosis. That is when we have accumulation of mucus secretions in our body, and it particularly affects our respiratory and digestive systems. If this is not diagnosed and treated, it can cause death at a very early age. There are treatments out there, and there are treatments being worked on that allow adults to live a relatively normal life into adulthood. Okay. This is usually collected by a dermal puncture from the newborn onto what's called a Guthrie card, and you should see that in your textbook. Galactosemia, this is when our bodies can't break down galactose, which is a sugar from milk. So when babies have this deficiency in this ability to break that sugar down, they don't gain weight appropriately, they don't grow appropriately, they can have liver and bleeding issues. So if it's not diagnosed and treated quickly, it can be life-threatening to infants. And the way we can help to manage this disease or this disorder in our babies is by just having a diet low in lactose. Hypothyroidism, though this can be acquired, it also can be something that we have at birth or congenital, you'll hear it called. Basically, our thyroid's responsible for making many iodine-containing hormones that we need for growth, brain development, for regulating our metabolism. So if our thyroid is either not functioning completely or it's not functioning at all, we're going to have delays in growth, intellectual disabilities. The great thing is this can be treated with oral thyroid hormone. Phenylketonuria or PKU. This is a test that is done on the neonate, and then it's also repeated at about 10 to 15 days after birth. And this, when someone has PKU, or maybe has PKU, they get a buildup of phenylketone because they don't have an enzyme that they needed to help break down phenylalanine, okay? So that's why you get this buildup. If it's not treated, it can cause damage to our brain tissues, our heart problems with our heart, skin disorders like eczema. PKU is managed and treated with a diet that is low in phenylalanine. Sickle cell disease, I think that's the last one we're going to talk about here. Sickle cell disease, you've probably heard of that as well. It is actually a group of disorders in which our hemoglobin has an abnormal structure. And the abnormal structure is because of a genetic mutation. So it's from birth. In some forms, this abnormal structure of our hemoglobin, the one that you probably most commonly heard of, our hemoglobin is this nice little donut shape. In this type of sickle cell disease, it takes on a crescent shape. So it's not its normal shape, which actually causes a problem of our blood vessels moving through our blood cells, moving through our small vessels, all right? When that happens, we're not getting those blood cells to our various organs, and you actually have this deep organ pain. It's very painful. Sickle cell can be managed and treated by staying well hydrated and avoiding situations in which we are in low oxygen environments. So living in higher altitudes is not a great idea. This is important to know if someone's going into a surgical procedure, because when we have anesthesia, that puts us into a low oxygen environment. So that's also a dangerous situation. So states have, let me go back actually, because I want to show you that picture that I have there. State required blood tests are collected on special forms like the one you see in that picture. They have an absorbent area to collect, but there are reasons why they may reject our specimens. If those circles are not completely filled or if they're oversaturated. If those specimens weren't allowed to dry thoroughly, if they're contaminated, if that form was expired when we used it, or if the form is not received at the reference lab within 14 days of collection. So our job as phlebotomists, we're going to collect those samples. We've got to make sure those get packaged and sent to the appropriate reference lab. Let me see. Okay, let's talk a little bit about peripheral blood smears, okay? In some facilities, this might be a job that you will do as a phlebotomist. You see here, I've got two images. I've got a thin smear and a thick smear. So I'm going to talk about both of those a little bit here, but I also definitely want you to look in your book for this because there's a couple pages. Let me see. Yeah, pages 356 through 357. There are several figures and tables that are going to really help you to get a better understanding of this process, okay? Because it's kind of hard to just describe it in lecture without you actually seeing more of these pictures and then hopefully getting to try this out in the lab as well. So a blood smear is basically a thin film of blood spread onto a microscope slide that we're going to look at under the microscope. When someone's looking at these smears under this microscope, they're actually counting individual cells. They're looking at white blood cells, red blood cells, platelets for changes in size and shape and color to help aid in diagnosing certain conditions. So thin blood smears are prepared a certain way in which you're using two slides. You're going to get a drop of blood towards one end, and then you're going to use a slide to smear it towards the other. And that's where you get this fanned out appearance that you see on that top slide, slide A, the thin smear. You can do a smear from capillary blood, or you can do it from blood that's in a tube. After we have completed our smears, we do want to make sure to label them appropriately. Usually you're going to have that kind of fogged side of the slide where you can label, but you might not always have that. If you're actually doing a dermal puncture, you can actually have the blood drop directly onto the slide too. That's also an option. And remember too, if you're using a tube to access your blood, make sure that you use caution in the proper steps when you're uncapping that tube to make sure that you're not getting exposed, right? All right, let me see. So when we're talking about a thin smear like that, a properly made film will have a thicker portion, which you can see over there, right? A thinner portion, and that tail edge that's kind of feathered out, and it's usually going to be slightly rounded or straight, okay? And again, look in your book, you're going to have a better visualization of this. You don't want the blood smear to touch the edges of the slide either, if possible. All right, let's see. Thick blood smear, so that's the bottom one. That's a different type, obviously. And this one has more of an oval shape. Sometimes they'll have a round circular shape as well. These are actually done to detect the presence of malarial parasites in peripheral blood. Or excuse me, in peripheral blood, they might be too small to detect. So we do these smears, these thick smears. It's best to actually prepare these we said with the thin smears, you can do a dermal or from the tube. The thick smears are done ideally from a direct dermal puncture, dropping freely onto the slide. You're going to collect the large drop towards one side. You're going to place the corner of another glass slide into the center and kind of draw a spiral to make that circular or that oval shape. And then these need to air dry for at least 30 minutes. All right, let's see what else. Make sure I don't. Also on page 359, that's where you can see some different appearances of those smears as well. So make sure to reference those. All right, so let's talk a little bit about blood bank collection. So patients that require blood transfusions or any kind of blood products are going to require certain tests prior to receiving blood. So we're always identifying our patients, right? But when we're talking about blood donations and blood receiving blood, there's extra steps and extra precautions and extra labeling that goes into it. You see in this picture, you've got another wristband. When someone's going to get a blood transfusion, they're going to get a wristband specific to that blood transfusion. This is going to be called type and crossmatch or type and screen, okay? All patients have to be properly identified prior to the specimen collection. But like I mentioned, there's a more complete identification in this process. There are strict protocols that transfusion services and blood banks will use. And that's going to vary by facility a little bit. So you need to make sure you're familiar with your facility's procedures. Often, like I already said, you got this wristband, and there's going to be a number that you're going to have this number, and usually there's extra stickers that you can pull to place on appropriate paperwork, etc. You're going to have a number on the wristband. You're going to have the number on the specimen, on the requisition, on the blood product itself, and they all have to match, right? That unique number is only used once for that one patient, that one time. If they receive future blood transfusions down the road, new number, new testing, new everything. So make sure to review over the check your competency. It's on 13-6 on page 362 in your book, because that's going to give you some really good information on there. Let me see. So donor blood collection. So that was when we're talking about when we're going to give blood to somebody, right? Now, when we're collecting blood, phlebotomists might receive additional training to be able to collect blood. We might be collecting certain parts. We might not, we can collect red blood cells, we can collect plasma, platelets, plasmapheresis. So basically, apheresis is a technique in which one or more of those blood products, again, the red blood cells, the plasma, or the platelets, is removed during collection. Plasmapheresis, for example, is when you want to remove the plasma, okay? Because not everyone needs whole blood all the time. All blood products require that meticulous labeling, and blood donation kits must meet strict guidelines and requirements. They have to be at least 16 years of age, weigh at least 110 pounds, be in generally good health. They have to have eaten at least 4 hours prior to donation and not have donated blood within the past 8 weeks. In addition, when you go to donate blood, you're going to get a little mini physical of sorts. You're going to get your temperature, blood pressure, and pulse to make sure you're doing well in that moment. They usually also do a finger stick to check your hemoglobin to make sure it's not too low. Usually your hemoglobin has to be at least 11. And then donors also have to provide information on recent travel, sexual activity, and any medications that may be they may be taking in case that may affect their ability to donate at that time. 1 unit of blood when someone is donating is typically about 450 to 500 mils of blood, and it takes several minutes. So if you've ever donated blood before, you're in this reclined position, comfortable as you can just relax while this process is taking place. Let's see. In the blood collection bag, there is an anticoagulant that will help to preserve our blood donation for 21 days. It does have to be mixed appropriately. Sometimes there's a machine that actually does that automatically as the blood is being collected. But sometimes as a phlebotomist, it's going to be your job to be manually mixing that so that the additive gets evenly dispersed. So it's important to note that if the blood, for whatever reason, the bag doesn't fill completely with blood, now our additive to blood ratio is off. And unfortunately, that blood can't be used. But that's really important. There's also something I want to mention too. It's called Autologous Blood collection. This is when people actually can donate their own blood for their own future use. What you might see this done for most commonly is when you have an anticipated surgical procedure where you might lose a significant amount of blood and you want to have your own blood ready for you. But you have to meet certain requirements to be able to do that. So if you're going to donate your own blood, you have to have an order from your provider, your doctor. You have to be capable or healthy enough to replace that blood on your own. Your hemoglobin has to be at a certain level as well. And surgical procedures must be scheduled for more than 72 hours out from donation. Again, so you have time for your blood to regenerate back to regular. Therapeutic phlebotomy. So this is when we intentionally remove blood from somebody, not to donate to somebody else, but because of certain disorders. So polycythemia vera, or hemochromatosis are two reasons why you're going to see this happen. Polycythemia vera, that's when our red blood cells overproduce. So our blood is too thick essentially, and we need to get some off. Hemochromatosis is when our body stores iron in abnormal amounts. And that's again, why we're going to donate some of our own blood. Polycythemia vera blood cannot be given to other patients. So it's not like you can't donate it. In some instances, blood with hemochromatosis can be used for donation. Because patients that are going in to donate, well, I don't know if donate's the right word, but because they're having therapeutic phlebotomy, they're not the healthiest of patients. So these patients are going to require, kind of closer monitoring. Arterial blood collection. This is blood collected directly from an artery for special tests that help to determine the ability of our lungs to exchange carbon dioxide and oxygen. So you're going to hear arterial blood gases. That's what we're talking about, right? Arterial blood gases, it's measuring the partial pressure of oxygen, the partial pressure of carbon dioxide, and our pH in our blood. This is not something that's typically performed by a phlebotomist, but we can be trained to do this. You may, and keep in mind, this is a very painful procedure for patients. So sometimes a local anesthetic is actually administered prior to the draw. Some reasons you might see arterial blood gases being drawn: COPD, so chronic obstructive pulmonary disease, cardiac failure, respiratory failure, severe shock, respiratory distress syndrome, and there's some others as well. These are done stat usually. Before an arterial puncture is performed, an Allen test or a modified Allen test is done. You do need to be familiar with that. Basically what it is, and you can look in your textbook too, but it's when you have the patient make a fist and whoever's going to be drawing the blood applies pressure to the major arteries that supply blood to our hand. You're going to have the patient relax their hand then, and because we've cut off the two major arteries to our hand, the hand's going to look pale, all right? What you're going to do is whichever of those arteries that you're going to use for their arterial blood gases, you're going to release pressure off of that one artery. It should only take about 5 to 15 seconds for the blood flow and color to return back to those hands and fingers. That is a positive Allen's test. That means we can use that artery because we know the other artery is going to supply a sufficient amount of blood to the hand. If the color and blood flow takes more than 15 seconds to return back, we cannot use that hand for arterial blood gases. Arterial blood gases are placed immediately in that ice bath or that slurry, okay? Let's see, I think venous access devices, yeah. So venous access devices, I think this is the last thing we'll talk about, yes. So venous access devices, or you might see them abbreviated VAD. Was that on the other slide there? Yes, okay. There we go. These venous access devices are typically like a hollow tube, which is called the cannula, that has been inserted into a vein and then it's left there. And this is for a variety of reasons, okay? And these access devices are often accessed intermittently to either draw blood and or administer medication. So they will either have a saline or a heparin lock, all right? And either one of those, whichever is used, more common you're going to see saline, but sometimes heparin, is to keep that line from clotting off and being non-functioning, right? So let's see. So collecting blood from a venous access device is not typically performed by a phlebotomist, but it's not uncommon for a phlebotomist to be there to assist, and that could be there to assist in getting the evacuated tubes ready, and then also transporting the specimens and handling the specimens appropriately, which we know is our job as phlebotomists. When blood is being collected from a venous vascular device, access device, excuse me, if I could talk, I apologize, a venous access device. The first 5 cc's of blood actually has to be discarded. It can't be used for testing because it can cause erroneous results or inaccurate test results. And that's because it kind of reduces that risk of contamination from that saline or heparin flush, whichever one was used. There are some venous access devices that are called central venous ports or shunts, or PICCs, which is a peripherally inserted central catheter. The PICC line is actually introduced, so it's initiated in the vein in an arm, but then it's threaded to a central vein, typically the inferior or superior vena cava. An arterial venous fistula, which we've talked about in a previous lecture, that is a surgically inserted shunt that connects an artery and a vein and is used for hemodialysis. You are never going to be accessing an AV shunt or a PICC line as a phlebotomist. Whenever we're using venous access devices, just keep in mind that the chance of hemolysis is greater. And when we do collect blood from a venous access device, we use a special, what's called a Huber needle and a syringe. And we want to make sure that we're making those transfers from the syringe to our evacuated tubes quickly and getting them to the lab as quick as possible. Okay, I think that's it, guys. Yep, we're all set. So that's it for chapter 13. Thanks, guys.